Hello, everybody, and welcome to my YouTube channel. And today we'll discuss about a common topic that we practice in regular life, specifically the intensivist, but that may not be very common for physicians who are admitting patients or managing a certain kind of sick patients in ICU or HTU. This was my talk in Epicon 2025 ventilator workshop, and I thought to bring that to you guys. So the topic was securing airway in invasive and non-invasive ventilation. We all are aware of this picture. This is the polio pandemic in the middle of the 19th century, where we have started using ventilation to give respiratory support to these patients, and this is negative pressure ventilation. Now, what we are doing presently, which is called positive pressure ventilation, when we are putting a tube and give positive pressure within the lung and forcing air into the lung of the patient. Now, another way this negative pressure ventilation was different from the current practice is that here the patient's airway was not secure. You can see the head of the patient was out and the whole body is within a iron chamber, which is called iron lung. Now we'll start with our case. A 61-year-old lady, carcinoma base of the tongue, locally advanced progressive disease, and received post 2 cycle of chemotherapy. So that means this patient has a difficult airway if we need to intubate. Now this patient admitted in the ICU with a neutropenic sepsis and septic shock at night around 11 p.m. Patient was requiring noradrenaline and vasopressin with a very high dose. When you do a blood gas, it shows a pH of 7.2 with metabolic acidosis along with some respiratory acidosis. We try to resuscitate the patient with fluids, but even after that, acidosis was persisting, no significant improvement in hemodynamics. As I mentioned, this is anticipated to be a difficult airway for people who are working in oncology setup with a restricted mouth opening of 1.5 centimeter. The patient is little drowsy but arousable, obeying basic commands. She is mild tachypneic and she wasn't put on ventilator, BiPAP NIV with 5-liter oxygen. So when my on-duty registrar called me, I asked him better to intubate this patient in a planned manner. But because it's a difficult intubation, they asked the anesthesia fellow to stay there as standby. The doctor feel that the patient still doesn't have any indication for intubation because she was conscious, obeying command, not that tachypneic, not desaturating with supplemental oxygen IV. So we were really apprehensive about this patient. So we called the head neck fellow also to have a look that if during crisis we're not able to intubate, can he do a tracheostomy? He also feel that presently patient is stable and no condition indication for a tracheostomy at this moment. And if required, just let us know. We'll try to chip in. But do you really think, that this patient's airway is secured or need to be secured? Whenever we are talking about airway, we are talking about four questions. When to secure an airway, how to secure an airway, how to confirm that tube is in position, and how to maintain the tube with minimum discomfort to the patient. So when you are talking about intubation or securing airway, so that can be because of this few physiological question or conditions, like there may be concern related to airway. Patient may having a respiratory failure, maybe because of hypoxemia, it's a type 1 respiratory failure, or maybe a ventilatory failure, that is called type 2 respiratory failure. Here, when you are trying to control the respiration in optimal level, you may need to take control over the airway because with an NIV, you cannot control oxygenation and ventilation to the full extent. May need to intubate or securing airway because of cardiovascular reason, that is in case of refractory shock, which is called type 4 respiratory failure. In this situation, because the patient is having a low blood pressure maintained with vasopressors, the blood circulation will be deviated from the skin and striated muscles to the vital organs like brain, heart, kidney, liver. And as a result, the striated muscles were not going to get adequate circulation. Here we know that diaphragm is a striated muscle. And in this situation, when the patient is septic, hypotensive, in acidosis, just because of increased metabolic demand, the diaphragm need to work more. On the other hand, he's not getting adequate blood supply. So there can be a rapid respiratory failure in these type of patients. Neurological causes are mostly because of either because of hypoventilation or because of airway issues. So patient may be aspirating or patient may not be able to maintain airway. And for in severe metabolic acidosis, sometimes we need to secure airway just to control the ventilation. Because sometimes they're so acidotic that if they start getting fatigued, and again all the muscles on the physiological mechanisms that's happening in the body during those respiratory muscle contraction may get hampered with alteration in the pH because all these activities are enzyme dependent. As a result, there may be a respiratory muscle failure and eventually the pH will drop precipitately further and may have an arrest. So these are the physiological rationale of intubating a patient. You have to add on the etiology, you have to evaluate the etiology. When you're talking about airway, it can be because of obstruction. Maybe patient has have a foreign body, may have a epiglottitis, maybe a burn, inhalational injury. All those situations can cause an obstruction. There can be collapse because we know that pharynx or upper respiratory tract has a part which is basically formed by muscle and soft tissue. Now, the patient has a very poor GCS. Patient may start losing airway. That's very common with patient with an OSA. In that situation, we need to give a positive pressure to maintain that airway. The patency of the airway need to maintain. And next can be an aspiration. The patient is unconscious. Patient has a vomiting. A patient has an upper GE bleed. Patient may aspirate, may not able to handle the volume. Or even if the patient is not have an active vomiting or bleeding, there may be microaspiration because of the poor GCS, which leads to suppression of reflexes in the upper respiratory tract. So this is the anatomical structure of pharynx. We know that it's a concave shaped musculofascial passage connecting the oral and the nasal cavity with the larynx and the esophagus. The oropharynx is the main channel for flow of air from the oral cavity to the larynx. And this part of the pharynx is a collapsible structure, as I mentioned, mainly formed by muscle and fascia, and that it all depends on the tone of the muscle. If the tone of the muscle is suboptimal, the person may collapse and patient may lose his airway. Now, do you think these modalities are enough to secure an airway, like a bag mask ventilation with a proper maintenance of the airway, LMA, or a combi tube? Not really. They can keep the airway patent, but they may not be able to keep the airway secured, specifically against aspiration, or may not be able to control the whole aspect of ventilation and oxygenation. So to prevent aspiration, better to have a endotracheal tube inside the trachea because it has a cuff, as you can see. Once you inflate it, there will be no further leak, and you can give a positive pressure ventilation. Also, can prevent aspiration. When you're talking about airway patency and gas flow, specifically without securing an airway, so in negative pressure ventilation or in that kind of flow pattern, when the patient is spontaneously breathing, there are muscles like cricothyroid and posterior cricoarytenoid, which usually contracts and leads to glottic widening, and as a result, there's a decrease in resistance. On the other hand, if you're giving positive pressure ventilation or that kind of flow pattern, when the patient is spontaneous or patient when the patient is expiring, in that situation, usually thyroid retinoid muscle contracts, and as a result, there is a glottic narrowing and there's the increased resistance to the gas flow. This all happens because of bronchopulmonary C5 receptor, rapidly adaptive receptors, and slowly adapting pulmonary stretch receptor that is present in the airway and the lung. This you can clearly see in the picture that whenever where we give a positive pressure ventilation, right, there is a offloading of the diaphragmatic contraction. What happens? There's a cricothyroid muscle activity goes down, and thyroid arachnoid muscle activity goes up. Like as I mentioned in the previous picture, that posterior cricoarytenoid muscle, when they contract, they widening the glottis and decrease resistance. On the other hand, thyroid arachnoid muscle contracts because of glottic narrowing. So, what is the physiological rationale? Physiological rationale, what I could have interpreted is that so when we are trying to use NIV to decrease or offload the respiratory muscle to diaphragm, there will be associated glottic narrowing, respiratory tract narrowing, and there may not be that amount of increase or improved flow into the respiratory tract because of increased resistance. So we have to optimize it according to the patient's requirement. And no unnecessary positive pressure ventilation should be given. Next challenge will be to choose a correct patient. Because in an inappropriate patient, if the success rate will not be there because of the maybe because of compliance issue, because of inappropriate interface. So this is the ISCCM guideline for use of non-invasive ventilation acute respiratory failure. These are standard indications as I've mentioned, like acute exacerbation of COPD with acidosis, respiratory acidosis, pH 7.25 to 35. Should not try to avoid above 7.35 because it will make patient alkalotic. And below 7.25, we should be very cautious. And below 7.2 or 7.15, we should not use NI. We should go for intubation. Acute cardiogenic pulmonary edema. Next is in case of immunocompromised patients or palliative patients and post-transplant or peri-transplant scenario. These are grade 1 indications, except that there are other indications like in acute hypercapnic respiratory failure due to asthma, bronchiectasis, obesity, hypoventilation, neuromuscular block disease with decompensation, chest deformity, acute hypoxic respiratory failure in cardiogenic pulmonary edema is a standard indication without shock. In shock, we better to avoid. In ARDS, mild hypoxia. We know that in mild hypoxia with a PO2 to ratio 200 to 300. In pneumonia, a little bit off-level indication. And definitely in acute respiratory failure because of immunocompromised patients. Because once we intubate them, risk of complications or VAP increases significantly. There are special conditions when you have to use judiciously, like post-extubation. In post-extubation, NIV usage should be prophylactic, not empiric or therapeutic. Prophylactic means you extubate the patient, put them on an IV, rather than waiting for them to have a respiratory failure and then try to rescue the situation with an NIV. Studies have shown that if you use prophylactic NIV in high-risk patients, that means high-risk means patient with underlying cardiac disease, patient with underlying lung pathology, and patient with a raised intra-abdominal pressure. In all these situations, prophylactic NIV helps significantly. Same thing is for post-operative patients, but if you use them as a treatment, that when the patient already have developed respiratory failure, you try to rescue the situation in NIV. Studies shown that it leads to poor outcome, more complications because we are delaying intubation in this group of patients, and there rarely there will be a success. So now next is what are the contraindications. And if you look at the contraindications, mostly it is related to airway. Inability of the air patient to protect airway because of comatose condition, cerebrovascular accident with bulbar involvement, as a result suppression of cough reflex. Patient is confused or agitated. Inability to fix the interface because of there may be facial injury, facial abnormality, burn, trauma. Hemodynamic instability, already explained. In hemodynamic instability, perfusion to the respiratory striated muscle will be compromised and might lead to sudden respiratory, precipitous respiratory failure and drop in pH because of combined metabolic and respiratory acidosis. Except that GI symptoms are vomiting and obstructed bowel, hemorrhage, hemoptysis, all this leads to risk of aspiration, copious secretion, and in post-cardiac arrest, obviously you don't have a control over the ventilation of the patient. When you look at the timing of respiratory failure, you usually divide them into immediate, early, and late. And three, three types has different etiology, different causes. For immediate, which is around, we can see 20%, 15 to 20%, that's mainly because of airway. You take the patient's tube out, patient is not able to maintain his airway start collapsing because of multiple reasons, and we need immediate intubation. There are different challenges while intubating patients in ICU. These are not like intubating in OT because of patients are much stable and those intubations are mainly planned. So what are the challenges in ICU? Because these patients are unstable with limited physiological reserve, unoptimized comorbidities. Patient may have a blood pressure of 200 or maybe uh, blood pressure of 80/40. You can have both. Clinical stakes are high and time pressure is intense because patients are deteriorating, desaturating unless you're able to secure LV very fast. The outpatient will collapse and patient can have a cardiac arrest. And that's why the complications while intubating in ICU is much, much higher compared to anesthesia. Inappropriate positioning, immediate environment may not be optimal because you may not have any extra hand or helping hand like you can get in OT. Don't have much flexibility to examine and assess beforehand. So patient land in ICU bed, saturation is 60, you need to intubate. Very limited scope to evaluate and plan your intubation, even though we need to do some planning, some assessment, depending on the time you can have during the process. And difficult to get optimal intubating conditions because you may not be able to give adequate anesthetic drugs, adequate muscle relaxant in certain situations. And it showed that the real-time incidence of complication can be as high as 13% in ICU compared to very rare complications that happen in anesthesia. So it is the real-time data. First one is an old study from anesthesial journal anesthesiology where they look at 297 intubating procedure that happen in the ICU and ER. And they found significant complication is hypotension and peri-intubation cardiac arrest, which is around 3%. Remember this number because we'll see another study which has happened in the recent past. What are the other complications like difficult intubation, esophageal intubation, aspiration, hypoxia, and hypotension? These are all predictable complications. But the point is the risk and the frequency of happening these complications are much higher in ICU and ER. Another study published in 2012 in BJA, 794 patients, 91% has a first success intubation. They also found that acute respiratory failure and shock are two independent predictor of complications, and complication can be as high as 40% in presence of these two conditions, which are the main two causes of intubation in ICU. So whenever we are planning to intubate, we have to ask four questions. Is the mask ventilation likely to be successful? So that's we need to ensure before giving any anesthetic drugs or sedative to the patient. Even a very small dose of sedative in a patient with an OSA can cause a profound uh, loss of sensorium. Second, if the intubation likely to be successful, we need to ensure that before giving a muscle relaxant, because you give a muscle relaxant long acting in absence of sugammadex, you may not, if you're not able to intubate, that will be a very complicated situation. If it looks difficult and we are not sure about it, is there an obstacle to doing a fiber optic intubation? You can go for a planned intubation in certain patients if you find that the airway is difficult and you're not sure whether you can intubate after giving muscle relaxant. There are contraindications of fiber optic intubations like maybe a bleeding from the upper airway, which is very common after radiotherapy, as our patients, as I mentioned. Or if you're not able to secure airway by any mean, what is your plan B? Are you going to put an LMA or going to do a FONA, that is front of neck access? So difficulty of mask ventilation can be classified depending on certain risk factors. Why it is important? It is important because you are going to pre-oxygenate these patients with this mechanism, technique of mask ventilation, maintaining airway till you prepare everything for intubation. So there are different gradings, like grade 1 means difficult to ventilate by mask. Grade 2 ventilate by mask plus oral airway. You try to put an airway as a rescue technique. You give muscle relaxant or have been given muscle relaxant because of intubation purpose. Grade 3 difficult mask ventilation despite above everything and required by two providers. One person is holding the mask, one person is arming, even then you're not able to ventilate. And grade 4 is unable to ventilate with or without use of muscle relaxant. You've tried everything, you see depend anesthesia, you depend the muscle relaxant level, and even then you're not able to ventilate. And the incidence of difficult mask ventilation can be as high as 5%. What are the risk factors I need to look for? These are mnemonics called bones and moans. Bones means bones stand for beard individual, obesity with a BMI more than 26, no teeth. In that case, the airway, the may collapse with the absence of teeth. The structure of the oral cavity may not be maintained. Elderly more than 55, so the age cutoff is not more, doesn't look like an elderly, but and patient with a snorer because they may have a OSA component. And for moans, it is goes by mask still impossible or difficult because of any oral abnormality, maybe a burn, maybe a trauma, fracture, obesity with a BMI more than 26 or any evidence of upper airway obstruction, advanced age, no teeth, and snorer. So when you are planning to intubate, better to evaluate the adequacy of the oropharynx by any mean. Try to look at the oral cavity from outside to understand what is the space inside, what are the structure you can see. Now, classical teaching is that you should go for a Malampatti chlorine, which called Samsung Young's modification. So here you can see the grade 1 means the partial palate, soft palate, hard palate, and uvula. In grade 2, you can't see the partial pillars. You can see the soft palate, hard palate in uvula. Class 3, you can't see soft and hard palate, and in class 4, only hard palate. Now, this classification is valid when you ask the patient to sit in front, and you also have sit in front of the patient. Ask them to open the mouth and protrude the tongue. But when you are in ICU, you have to evaluate these patients in a bedridden position. Okay, in that situation, if you can ask the patient to open his mouth and protrude the tongue, usually the assessment is appear difficult by one class. That means if the patient is Malampati grade 2 in sitting position, it will appear grade 3 in lying down position. Along with that, you have to evaluate for the narrowness of the palate. Those things all indicate that this is going to be a difficult intubation because the oral cavity is small. Putting a laryngoscope, putting a tube within the oral cavity can be little challenging. And there's a mnemonics we need to remember, which is called push. Grade 1 means you can see fossil palate, uvula, soft palate, hard palate, as I mentioned. Grade 2, uvula, soft palate, hard palate. Grade 3, soft palate, hard palate, and grade 4, hard palate only. This is called push mnemonic. If you do a laryngoscopy and you can look for the Cormack-Leon classification, you can see that in grade 1, you can see all the structure, both vocal cord and everything. In grade 4, you can't see anything. In grade 3, you may see some part of the posterior adenoid, can't see much. Maybe epiglottis is visible, and in grade 4, no vocal cord opening is visible. So this is the modified Corman-Laird classification, which divide grade 2 into grade 2A and grade 2B. Grade 1, full view of the glottis. Grade 2A, part of the glottis, and that is the cord. Grade 2B, only the arytenoid is visible. Grade 3, only epiglottis. And grade 4, no part of the glottis. These all are classification of an anatomically difficult airway. And there are different classifications of scoring system to identify it, but these are not practically applicable in ICU at least. But we can look for Lehman's law, which is pretty simple, which includes look externally, look for external abnormality that should make it difficult, like a burn contracture, restricted mouth opening, it's become obvious. Evaluate 332, 3-4 mouth opening, 3 for thyromental and thyrohyoid distance. Malampati classification, any suggestion of obstruction, any history, clinical finding like stridor, and what is the neck mobility. Now, once you will do not able to intubate, you may fall back for LMA, that is the extraglottic airway. So beforehand, you should evaluate the difficulty related to extraglottic airway, which is comes by the mnemonic of ROTS. R for restricted mouth opening, O for any obstruction, D disturbed or distorted airway, and stiff lung or spine. In that situation, putting an LMA in a right place and also ventilating with an LMA can be challenging. Here, the difficult insertion is usually less than 1%, but the LMA failure can be up to 5%. That means you're not able to ventilate the patient. Put it in the place, but you're somehow not able to ventilate. Then you fall back for phone or front of the neck access. In that situation, for surgical airway, difficult, what are the concerns? This is called short. As for previous surgery in front of the neck, then the anatomy will be distorted. Is any hematoma, obesity, radiation therapy, and tumor. If there's a large tumor in front of the neck, obviously you are not able to go through the tumor into the trachea. After the anatomically difficult airway, an ICU has a different challenge. It's called physiologically difficult airway, like our patients, which was a physiologically difficult airway too, because of acidosis and hemodynamic instability. And this is a study done in 29 countries. From India also has we have participated. Dr. Shaila Maitra, as you can see in her name in the author list. And they look at the intubation practice and adverse peri-intubation events in critically ill patients. This is a very recent study. And they have found that the major concern is hemodynamic instability, which can be seen up to 45% cases, followed by hypoxia, which is around 9 to 10%. And most interestingly, the peri-intubation cardiac arrest is still around 3%, just that it used to be, just like that it used to be nearly 20, 30 years ago. So peri-intubation cardiac arrest has not gone down, even after availability of so much gadget and everything. And this is the risk, patient-related risk that has been mentioned in or in IDEA guideline 2016 that, as I mentioned, challenging anatomy, inefficient pre-oxygenation that we'll discuss why the pre-oxygenation is challenging in ICU and why those patients desaturate very rapidly. Along with that, hemodynamic instability, and most importantly, waking up is not an option. You have to secure an way. You have to control over the etiology that has led to this patient's critical condition. So, for a physiological difficulty airway, these are the four very important risk factors: severe hypoxia, hypotension, severe metabolic acidosis, and right ventricular dysfunction. Why right ventricular dysfunction? Because once you change from a negative pressure to a positive pressure, it will increase the load on the pulmonary circulation and eventually on the right ventricle. If the right ventricle has failed already, there will be a rapid dilatation and severe hemodynamic instability, which will not going to respond with any intervention. And their objective scoring system, which is called Makocha score, which has been divided into factor related to patient like Palamberti score, obstructive sleep apnea, reduced mobility of the spine, and limited mouth opening, that is less than 3 centimeters. Factor related to pathology like coma and severe hypoxia, and factor related to operator like a non-anesthesiologist. So it has weighted or emphasized that it is better to have anesthesiologist while you are doing the intubation in acute situation because they are definitely much more skilled and well aware about all the recent guidelines and the technologies. It has shown that sensitivity is around 73%, and it was not validated for video laryngoscope. And availability of video laryngoscope and the practice of video laryngoscope has changed the airway management in ICU and case of difficult airway scenario. This is the guideline by the American Society of Anesthesiology. And as I already mentioned, most likely are going to face either a difficult ventilation, intubation, patient cooperation, and need for tracheostomy. All these steps, it can be difficult. And you have to choose between the options like awake intubation and intubation under anesthesia, non-invasive technique versus invasive technique, and spontaneous ventilation or ablation of spontaneous ventilation by a muscle relaxant. As we are discussing in a managing sick patient, pre-oxygenation is very important. If you can increase the oxygen reserve in the lung, you may get a longer apnea time and longer time to secure airway without any complication or desaturation. So you can start with a supplemental oxygen with a nasal prong face mask or high flow mask. You can use an IV or you can use HFNC and or the fancy name which is called Thrive of the same machine of HFNC. Now, what are the challenges in ICU patients for in terms of pre-oxygenation? When the patient has a normal lung, you just have to replace the nitrogen in the lung with a supplemental oxygen, and you can see that in case of normal lung, it's very easy to improve oxygen level. But when the patient has a pathological lung, like in ARDS, very small lung is already functioning, which is called the baby lung. Now the FRC has significantly decreased. So even if you replace that part of the lung with a purely oxygen, still the apnea time will not increase significantly. In that situation, better to, if we can recruit some part of the recruitable lung, for example, in ARDS patients, then it will increase the FRC and eventually it can increase the oxygen reserve for this lung. So because of that, there is a significant benefit of pre-oxygenating critically ill patients, ICU patients with a pulmonary pathology or in ARDS to with a non-invasive ventilation. Similarly, non-invasive ventilation can be beneficial for morbidly obese patients because of a similar mechanism. When you compare NIV with a conventional face mask, it has shown that PO2 is significantly higher with an NIV without any clinical significant effect. But PO2 was higher after NIV. Why? How it works? Because once you give positive pressure, it combats with raised intra-abdominal pressure that happens in morbidly obese patients. And eventually, it will open up the collapsed alveoli at the base of the lung. You can clearly see in these patients, once you try to intubate, the base of the lung is definitely collapsed. And as a result, they will also function as a baby lung, small part of the lung which is normally functioning. It has been compared, that is, NIV has been compared with an HFNC in pre-OptiProp study when they have pre-oxygenate and apneic oxygenate 100 patients before a surgery. We found that lowest TTSO2 was with an HFNC. There was a mild desaturation, and the median lowest SpO2 was more with an HFNC, and patient discomfort was more with NIV. It is obvious because you have to put a tight mask compared to a nasal cannula. Next is apneic oxygenation. Sometimes in a difficult airway, intubation time can be prolonged. Can we give supplemental oxygen during the procedure? And it is a must in ICU. We should always try to use apneic oxygenation depending on the facility available. If you don't have an HFNC, you can give with a nasal cannula. Put a nasal cannula and start with 15-liter oxygen. It will improve oxygenation status and can apnea time be increased by 2 to 5 minutes. Better technique is HFNC or Thrive, that is transnasal humidified rapid insufflation ventilatory exchange. Complicated name. Principle is same, just like an HFNC. You start with a high flow cannula, 60 liter, with warmed humidified oxygen. It can get a combined benefit of apneic oxygenation with continuous positive airway pressure or gas exchange to a flow-dependent day-space flushing. It increases apnea time by enhancing the apneic oxygenation and provided apneic ventilation, reduce rate of rise in CO2 compared to one-third that is expected, and apnea time has been shown to increase by 14 minutes again in a normal lung in a peri-anesthesia situations. If the patient has a pathological lung, it cannot assume just by supplemental oxygen we are going to get away with a prolonged apnea time. So HFNC has been compared with NIV as I discussed physiological rationally. It has been shown in a mildly hypoxic patient with a POT value less than 300. This was done in 313 patients over 28 ICUs. No difference in severe hypoxia, but in terms of POT ratio, NIV does better compared to HFNC. Similarly, when they compare uh, HFNC with NNIV in 796 patients in a 7 RCT, making a meta-analysis. They found that severe complications like cardiac arrest, including severe desaturation, is less with NIV plus minus HFNC compared to a non-pressure mask. You put a face mask or something. When you're intubating a patient in ICU, those are emergency procedures, and most of the patient can have a full stomach. At least we should assume that patient have a full stomach, and so the risk of aspiration is more. So the conventional practice is to go with a rapid sequence intubation or RSI. But we need to remember it's an expert and advanced technique require training and competence. Not that easy. So what are the steps? Pre-oxygenation, manual inline stabilization. If you're suspecting a cervical spine injury or a trauma or an unconscious patient, have to do a quick IV induction with anesthetic drugs and neuromuscular blocker. Yes, neuromuscular blocker we need to be used. We see what is the evidence. Give cricoid pressure, which is called Salix maneuver, and followed by intubation. Now the cricoid pressure has become little uh, have a borderline evidence, not a strong evidence, so it become a plus minus intervention in Salix maneuvers. But for neuromuscular induction, it is a must. It has clearly shown that usage of neuromuscular into blockage improves first pass success rate by creating best possible intubating facility or intubating condition. Hypotension, that's a very common complications with cardiovascular collapse can be seen in 30 to 40% cases, and this is an independent predictor of post-intubation mortality, ICU stay, and hospital mortality. So what are the therapeutic options? You can load this patient with a fluid if available before the procedure. Some a lot of time you may not able to give adequate fluid. The patient is already desaturating. In that situation, usage of vasopressor, either therapeutic or prophylactic. Now, studies have shown prophylactic usage of vasopressor. That means when the patient is normotensive, starting vasopressor may not be helpful, but you should keep vasopressor ready and connected because once the patient start become hypotensive, preparing the drug can be a little tricky or may not be recommended. What are the drugs we use in terms of intubation or also to maintenance? These are benzodiazepines, propofol, or thiopental. But because of hemodynamic stability, we are gradually moving towards etomidate and ketamine, and they are presently recommended as a preferred drug. You can use opioid, dexmedetomidine, or lignocaine as an adjunct, either to decrease the need for anesthetic drugs or to decrease the complication or sympathetic drive related to intubation in this patient. Because these patients are sick, they are septic, a lot of cytokines in the blood, so their heart is always very arrhythmogenic, and they may have develop an arrhythmia just after the intubation procedure. In terms of neuromuscular blockage, the target is to improve first pass intubation success for both rapid and delayed sequence intubation. Delayed sequence intubation means put them on NIV, improve the oxygenation status. If the patient is restless, give some ketamine so that they tolerate the NIV better, and they will go with the intubation process. It has been shown that irrespective of the induction agents or route of administration, this is better. Improve the first pass intubation rate. For the choice, we all have been trained in the conventional laryngoscope, but this is the time We should learn to use video laryngoscope. This will become a must and must intervention or skill for a ICU and anesthesiologist. And studies have shown that the intubation success rate can be doubled with usage of video laryngoscope with decrease in complication in ICU patients. How it improves? It improves visualization of the glottis and the first intubation in even in pre-hospital settings, ICU and ED. This is a meta-analysis involving 9 trials involving 2,000 patients. It shows that first success rate was twice as high with your laryngoscope, as I mentioned, compared to conventional laryngoscope. And when we look at the challenges related to ICU and ER, this is as per NAV4 report that is from the West, that is from UK. Main concern is the non-availability of appropriate equipment like video laryngoscope. Even in the Western countries, it is not routinely available. If it is available, availability of the training and choice of appropriate equipment, right equipment at the right time. These are the main challenges related to airway management. But to get a better access, better outcome, you should have a difficulty airway kit along with the standard equipments like supplemental oxygen, face mask, PEEP valve, suction equipments, large bore tonsillar suction. That is a Yanker. If the patient has a large secretion or vomited food particles, Yanker can be very, very helpful. Once you tube the patients, you have to confirm that it is in the right position. In ICU, in a chaotic situation, it can be tricky. There is strong recommendation to use capnography to confirm tube position in ICU, irrespective of the location, in critical inpatient, ICU, ER, or OT. Recent study, as I mentioned, that it has shown that still the usage of uh, ETCO2 to confirm tube position is only 1/4, 25%, as per the INTUBE trial. There should be a bundled approach, how to confirm the tube position, secure the airway, and do a chest X-ray to rule out any complication like pneumothorax. But we should not forget about airway securement when you are extubating, because in a difficult airway, once we extubate and the patients are desaturating, how are you going to intubate the patient again? So, airway exchanger can be really helpful. So, if you want to plan extubation in a difficult airway, we are not sure whether the patient will be able to maintain airway, so put a airway exchanger, extubate the patient, and keep the airway exchanger there, maybe for an hour or so. In our hospital, by protocol, we keep it for 3 hours, and the patient is not aspirating, able to maintain airway, we take it off. There are IDA guidelines, which every intensivist and ICU physician who are managing patients, sick patients, should be aware of it. Even if they are not able to perform all the intervention, they should be aware that when to call for help. So this part we have already discussed: pre-oxygenation, induction anesthesia, then followed by laryngoscopy and tracheal intubation. Better to have anesthesiologist, better to have video laryngoscope. Once we intubate, confirm the tube position by capnography. If not able to intubate, go by 3 attempts. In between, you have changed the laryngoscope, change your plan, try to understand the underlying pathophysiology, what is missing. Even after that, not able to intubate, go for supraortic devices, call for help, prepare for percutaneous surgical tracheostomy in these patients. Not able to ventilate with supraortic devices, go for a rescue mud ventilation. In that situation, compared you have to deepen the anesthesia, and compared to conventional bilic, you have to deepen your neurovascular blockage. You have to give more neurovascular blockage. Able to ventilate, good, go for surgical tracheostomy. If you're not able to ventilate, in that situation, it becomes a can't intubate, can't ventilate situation, right? Then you have to go for emergency cricothyrotomy. So it is very, very important for all the ICU physicians to be aware, trained in FONA, that is the front of neck access, at least in mannequins or in different workshops. So by this, I'd like to complete my presentation. Thank you for attending. And if anyone has any query, feel free to reach me to my YouTube video. Put your question and I will try to answer. Thank you.